Hi, everyone. My name is Robert Ye. I'm the director of the Smith Center for Outcomes Research and the Associate Chief of Interventional Cardiology at Beth Israel Deaconess Medical Center at Harvard Medical School. I'm asked to speak on the topic Future Directions in CTO PCI. These are my disclosures. So when thinking about what the future of CTO PCI is, I wanted to start with thinking about what were the unmet needs for CTO PCI, and I grouped these into a few different categories. There are technological needs, technical needs in terms of the types of techniques we use. There are unmet needs in training of CTO PCI operators. I think there are unmet needs in how we choose patients and physicians. And finally, there are unmet needs in evidence, and I'll talk a little bit about each of these in the next 10 minutes. As far as future technology goes, I've sort of titled this slide New-ish Gear. We have some new technology for CTO PCI, but I would say that most of the new technology that we've used and we will be using in the foreseeable future are really iterative changes to what we have now. I think we have a very good selection of wires and microcatheters here. I list some new wires, the Judo series of wires, which recently came available from Boston Scientific, and the new Recross catheter from a company IMDS, which is a over-the-wire catheter that has multiple ports and multiple lumens, which can facilitate antegrade dissection reentry potentially. But for the most part, the suite of technologies we have is very good and it's very effective. Some of the newer technologies that are currently being evaluated include technologies to address impenetrable proximal caps. This is the SoundBite crossing system. It's a wire that essentially is energized by shockwaves that are generated by a bedside console that present a sort of a jackhammer effect of the wire. This is a slide from Stefan Rinfrey, who's been intimately involved in evaluating this wire. I think we're going to have new, hopefully, information about the efficacy of this device in the near future. In addition, calcium continues to be a problem for CTO PCI. Here's a procedure that we did several years ago involving an antegrade dissection reentry and then rotational atherectomy into the subintimal space. And you can see here that this rotational atherectomy in the subintimal space led to a large perforation. So that I think a device that we're all really looking forward to for CTO PCI potentially is the shockwave intravascular lithotripsy. The Disrupt-3 CAD-3 study was recently completed, and I think we're expecting that the device will be in our hands sometime in 2021. Of course, this device won't have been tested in CTO, and CTO use will be off-label, but I think for those of us treating complex calcified CTOs, we're interested to see how this device will perform in dilating calcified arteries, particularly those involving long segments of subintimal passage. As far as the practice of CTO PCI is concerned, if you look at, this is data from the Progress CTO registry from Manos Prolakis, and we can see that in current practice among high volume sites for CTO PCI, procedural success rates are high. You can see near 100% success for JCTO scores, 0 scores, but even as you get into the 4 and 5, these are procedures that would have had less than a 50% chance of being completed, I think, a decade ago, and now they're being completed at an 80% clip. However, these aren't without their complications, and we can see here that the rates of MACE, of death, and perforation, they're all higher than they would be for non-CTO PCI, and in particular, they get higher as procedures get more complex, as denoted by the need for a retrograde procedure. So I think in the immediate future of CTO PCI, I think high volume operators have become very successful at opening these up. I think we've become better about making these procedures more safe, but really the immediate future of CTO PCI for expert operators should really continue to be to focus on improving safety of this procedure. Now that is in expert hands, but it turns out that on average, CTO interventions in this country are still highly unsuccessful. This is recent data out of the state of Michigan, which showed sub 60% success rates for all CTO PCIs undertaken in that state between 2010 and 2017. This is a time period where there was extensive training. There was growth in CTO PCI as seen by the blue line. So there's growth in the use of it, but MACE also started to migrate stable to migrating upwards a little bit, and success rate really not improving to the numbers that we would want to see. And we know the techniques are there to improve outcomes, to improve procedural success, as demonstrated by the Progress CTO registry, but they haven't been disseminated or adopted broadly. So that's really a failure of training. And part of the reason it's so hard to train CTO PCI is because the learning curve is very long. This is a study that we did led by Mike Young, Eric Sisemski, showing that among operators who do CTO PCIs, start out doing CTO PCIs, you continue to get better even well through your 50th and 60th CTO PCI case. And for some operators, that could take 3 or 4 years to accumulate that many cases. And so, but it's clear that there's a volume outcomes relationship here and a long learning curve. And because of that, I think there's been a failure to match complex patients with the right providers. And Bill Nicholson and Steve Ellis wrote a really good editorial on this subject in JACC Interventions related to that article in Michigan. And what they wrote was that, the obvious question is, how can we justify continuing our current model of CTO PCI in light of this evidence? It's become glaringly obvious that we need a structured organization to standardize practice for CTO interventions. And what they proposed was a more regimented training program with gradual escalation of complexity, standardization of case selection, creation of specialized CTO programs at facilities, funneling complex procedures to experienced facilities and operators, and the credentialing of PCI operators for CTO PCI. And I think that this sort of standardization, as we've seen, for example, TAVR programs, really needs to come into CTO in a much more regimented way. So other things about training. So I think that in order to train better operators, we really need to re-examine whether or not the existing proctorship have succeeded. We need to move, I think, from proctorship more to fellowship. So more dedicated longitudinal training where people really emerge from fellowship being experts. Training larger numbers. We need to move from training larger numbers of knowledgeable but not expert operators to training a smaller number of real specialists. And I think this is going to require a cultural change in referral patterns, carving out the most complex PCI as a subspecialty rather than as an extension of PCI. This is obviously going to take some political will to make this happen and some sacrifice. Finally, I'm going to end on evidence. What is the future evidence for CTO PCI? Well, I wanted to start off with the current evidence supporting the use of CTO PCI in randomized trials, which is our best evidence and the evidence that we really should rely on when we're making these sort of assessments. And our randomized evidence for CTO PCI is really, really poor. We have 3 randomized trials that are published: the Explore trial, the Decision CTO trial, the Euro CTO trial. 2 of these trials were negative. But these studies also were not really that well conducted. The Euro CTO trial, our best trial, was still terminated early due to slow enrollment. It wasn't blinded. So the question is, can we get better evidence to support what we do? And I think it's going to take a lot of political will to do this. A really important question: can we do a definitive study that demonstrates the clinical benefits of CTO PCI? Can we get broad support for doing this? Can we get funding to do this? Can we identify patients through this trial with the most to gain from the procedure? Finally, can we continue to improve on the safety of CTO PCI through better patient selection and improvement in technique and technology, and provide the evidence to show that we're doing that? And I show here the SHINE CTO sham controlled design, a study being led by Manos Proulakis, but it's a study that has not managed to get broad support or funding. And I think this is the kind of trial that we really need to, as a group, commit to really establish strong evidence to support what we do. So in summary, there are some new technologies that will become available that will improve the safety and procedural success of CTO PCI, but many of these improvements are iterative. The method to most improve CTO PCI outcomes is through better matching of complex patients who are failing medical therapy with the operators who have the skills to perform them. I think the democratization of CTO PCI is a laudable goal, but it's really unlikely. Finally, expert operators should continue to prioritize improving safety in the future, and we need stronger clinical evidence to support what we do. I think this is a win-win for everybody. It would catalyze greater enthusiasm, intellectual and financial investment to push the field forward. Thanks very much.